Hello and welcome to UF Health Wellness University. My name is Marcia Mott. Today we have a topic that I know many people want to hear more about, pregnancy and COVID-19. We have a great speaker who's going to answer as many questions as he can. You could submit your question at any time using the question and answer feature at the bottom of your screen towards the right. Just type your question or comment anytime you're ready to, and we're going to get that question answered after the presentation. Our speaker today is Dr. John Smulian, who is the professor and chair of the Department of Obstetrics and Gynecology at UF Health Shands Hospital. Dr. Smulian has been working hard to help women during the COVID-19 pandemic. Dr. Smulian, I'm going to turn it over to you now. Thank you.
Thank you very much, Marcia. I really appreciate it. And welcome to everyone. And delighted to be here myself, and I really appreciate everyone being able to join us. I am very happy to talk about COVID-19 and pregnancy, and it is something that has consumed much of not just my time, but my colleagues, those I work with, my friends, my family, the community surrounding us. And really, it has crept in some way, shape, or form into all of our lives. None of us have been unscathed so far by the pandemic, and I really expect that in some ways that is going to continue. There's obviously a lot of questions regarding coronavirus, the COVID-19 pandemic, and but none more so than the issues surrounding pregnancy. And it's created a lot of anxiety. It's created a lot of concerns on the really not just the healthcare system, but our patients and their families. And so it's really important to try and tackle what we know about this and what we don't know as well. And in some ways, what we don't know is much bigger than what we actually know, but we are learning, and we're learning fast. And there are much information that we can take away from our learning so far. So what I hope to accomplish today is to really do some education about what we do know about the COVID-19 pandemic and pregnancy, and then try and address what seem to be common themes and concerns about our patients, but also try and educate a little bit about how we as a healthcare system, but also as kind of the ecosystem of our environment, are trying to tackle this and really take care of our patients, moms, babies, families, and the community. So let's get started. So coronaviruses are a family of viruses, and some of them are actually considered related to the common cold, but that's actually not the coronavirus that we're talking about that causes COVID-19. So the family of these viruses, they cause illnesses with a range of severity. Most of them are pretty mild, but in the past really 2 decades, there have been some what we call novel coronaviruses. These are brand new variations of the coronavirus that have popped up on the scene, have had major outbreaks, caused problems, and then have sort of dwindled a bit. The 3 most common ones that you may have heard about, one is SARS, which is the systemic acute respiratory syndrome that first originated in 2002 from China. And then a related one that's MERS, which is Middle Eastern respiratory virus, that was about 10 years later, that came out of the Middle East. And then the most recent one, of course, is the COVID-19, where the first reports came out of Wuhan, China. This is considered new. And so these are different viruses than the mild type, and they can cause quite significant illness. So it's a little, I think it's a little helpful and to understand kind of the time frame of how all of this has just kind of exploded into our world. So I put together this little bit of a time frame to put things in perspective. And it goes from the beginning of December to kind of the middle of March. And so the first case of that's been recognized related to the COVID-19 virus probably occurred in December 1st, 2019. Now, it's possible there were cases earlier, but they certainly haven't been recognized, and we don't know where they might be. And then about 30 days later, China started to recognize there was an issue. They reported to the WHO an outbreak of something that they saw as new. About 7 days later, they identified that there was a new coronavirus. And then a couple days after that, they identified the genetic sequence of the virus and were able to share it with the scientific community around the world. About 4 days later, the first case was identified outside of China in Thailand. And then about 4 days after that, the CDC started screening at 3 airports in the United States. So we're only in the middle of January now. You can see how fast this is evolving. 4 days later, the first case was confirmed in the United States, and the CDC activated its emergency operating center. Just 7 days later, the CDC put out the recommendation to avoid travel to China because it wasn't clear what was happening there. 2 days later, the WHO declared a public health emergency, and then the first case of human-to-human transmission was described. So again, this is just 30 days after the first case was actually reported from China. The next day, CDC started quarantining people from the province where Wuhan, China is, and the US declared a public health emergency. And about a week and a half later, the virus was renamed and was called, instead of novel coronavirus, it was named SARS-CoV-2. There's a long set of reasons why that might be, but we all came to settle on COVID-19. A couple days later, the way to diagnose it started, it was expanded, and so the frequency started to go up. On March 1st of this year was when the first case was identified here in Florida. And 8 days later, a state of emergency was declared here in Florida. And then 2 days later, the pandemic, a COVID-19 pandemic, was declared by the World Health Organization. And everything else has actually been sort of well documented, but not everybody is familiar with this timeline. So I just pulled this information. Johns Hopkins has a coronavirus resource center that does some wonderful tracking. If you're interested, you can go to the website and to see state by state. You can get some county level data for things. You can also get the county level data from the state of Florida. But when you look at the rate, so this is the beginning of March. The first case was March 1st, as I mentioned. We had our first initial bump that went into mid-April. We had a bunch of shutdowns. Then things started opening up in May a little bit with the relaxation of some of the restrictions. And you see what we've been experiencing this summer, which is a massive peak. We actually had some restrictions go back into place. And this, you can see the frequency has actually started to come down, but we're still well above where we were back in May. And this is just the deaths, and you can see it mirrors the same kind of curve, although this actually kind of lags behind a little bit, the frequency. So this gives you a perspective of what we're dealing with as a state. It doesn't necessarily say what your community is. I also want to make a comment about how easy it is to transmit the virus. And these are estimates from very early in the pandemic, but still seem to be reasonably relevant, and these probably will be revised. And this image is actually a pretty nice image, and it is for every person that actually has the virus, how many people are likely to catch that virus from that person. And so that range is anywhere from 2 other people to a little more than 3 people. So 3 people for every person with the virus. So it is moderately contagious. And part of the problem with it is that if you're asymptomatic, it's hard to know if you're actually able to transmit the virus to somebody else. To compare it to other things, this bottom one is the flu, and so this is easier to catch and transmit than the flu. The virus that you hear about passing through cruise ships, not the most recent COVID-19 virus, but sort of the stomach viruses, that actually is a little bit more likely to cause catch. You can compare that to measles, which is highly contagious and is really easy to transmit. That's one of the reasons why we really like vaccines for measles, is that it's so easy to spread. But this puts things in perspective. This is Zika, Ebola, HIV. We do know that the virus is spread by respiratory droplets. This is primary way. That means the little mist that comes out basically of the mouth and the nose. We know we can detect the virus in the nose and throat, blood and stool. It's not really clear whether active virus can be found in the urine. We certainly can find fragments of the virus, but it's not clear that that actually can cause infection. It seems to be occasionally found, but very rare, in the placentas or the amniotic fluid that's around babies, or in the umbilical cord blood that goes from the placentas to the baby. We do know that once someone catches the virus, that they can actually shed the virus for up until about 14 days. Beyond that, it appears that it's very unlikely that the virus can be shed or transmitted. And whether or not it can linger on surfaces is unclear. Certainly the virus can be detected on surfaces, but that's also not clear that that virus can cause infection. So there's still a lot to be learned from that. So where are we in Florida? This is actually data that is as of last night. And Florida is number 2 in the country for states, over 600,000 cases so far. It's number 5 for those who have died from the virus, and that's we passed the 10,000 mark over the weekend. So the most serious area in the state is the Miami-Dade County area. They've had 152,000 cases. And actually, it's actually a little over 2,000 deaths. Marion County is next for the frequency in our region, followed by Lake County, Alachua, Suwannee, and Sumter. So that's just our immediate region. And you can see that these are pretty significant. And in these communities, it's likely that most of you know somebody or several somebodies, or had a family member, or even yourselves, who have been affected. So it is present. Now, just a little caution when you look at these statistics, they are based on the county of residence of the person. So it's not based on where they actually got sick. So if somebody from Marion County got sick and was actually hospitalized here in Gainesville, it would not count in the Gainesville area. It would count in the Marion area. So a number of us became very interested in this early on here, and I need to acknowledge Sonia Rasmussen. And Dr. Rasmussen is here in our Department of Pediatrics. She was also at the CDC for a long time and was director of their infectious disease program and really managed their major outbreaks over the years, including the H1N1 flu outbreak, the Zika outbreak, the flu, and we're very fortunate to have her here. Some of the information I'm going to be presenting is actually from her, but a group of us actually got interested in this early on, and whether or not it's a blessing or a curse, it has maintained our interest ongoing even up to this point. So I'm going to address 4 clear questions here. One is, are pregnant women at increased risk for severe disease or more susceptible to becoming infected with the COVID-19 virus, otherwise known as SARS-CoV-2? It's just much easier to say COVID-19. Second, what are the effects of COVID-19 during pregnancy on the developing baby? 3, can the virus that causes COVID-19 be passed from mother to fetus during the pregnancy or to an infant with breastfeeding? And number 4, what are the other consequences of the COVID-19 pandemic on pregnant women and their babies? So let's start with this first question. So here's what the data tell us. And this was the first report that came out of China that talked about pregnant women. And what they showed is in a small group of pregnant women that over 90% of the pregnant women were mild disease. Now, this was a small group, 147 pregnant women out of over 75,000 that they reported. And here, the non-pregnancy group seemed to have more likely to have moderate to severe disease than the pregnant women. So that was actually the first hint that at least pregnant women did not seem to get more severe infections. And this is some data that was presented from Italy. We all know Italy had a really bad outbreak in the spring. And so this is 77 women. Most of these were women who were infected in the 3rd trimester, the last third of the pregnancy. And similar to the data from China, a little over 80% had mild disease. And so there were no deaths among those who did get severe disease, but some moms did get very sick. This was actually also the first report that suggested that maybe there was a little bit increased chance of delivering preterm, at least 4 weeks before the due date. And this actually, what was notable is that about 1/3 of the severe cases delivered preterm. And what was really interesting out of this, which was our first hint, is that those who had severe disease who were pregnant, they also were more likely to have other conditions like diabetes, asthma, obesity, and other issues. So this wasn't just a simple thing of pregnancy. It looks like there's more to this story. So what about the United States? New York was hit especially hard, as you may remember. And the first report came out about 43 women who were tested when they came in for delivery. And that tested positive when they came in for delivery. Interesting, about 1/3 of these women had no symptoms at admission. And unlike the non-pregnant population, where you would have no reason to be tested unless you had symptoms, certainly earlier in the pregnancy, early in the pandemic. During pregnancy, we started testing women as they came in universally, so we tested them all when they came in, and we found that about 1/3 of the moms who were positive were asymptomatic. And what we learned from that is of those who had no symptoms when they were admitted for their delivery, about almost 3/4 of them eventually developed symptoms. And so what it's told us is that it was highly likely, at least with pregnancy, that at least at some point along the line, even if they didn't have symptoms first, that at some point they would develop symptoms. And importantly, well over 80% again had mild disease. Of note, almost half had cesarean deliveries for a whole variety of reasons. And although this was the first report and this was concerning, it doesn't look like it's that high anymore when we really have started to look at this over the past few months. In Washington State, another report, again, 7 were hospitalized related to the virus. And again, almost 90% also had mild disease. So this is actually very consistent and reassuring. So the CDC reported at the end of June, so this is only about 6 weeks old, a surveillance report of pregnant women in the United States. And so the thing that was so important about this is they actually had reports of over 300,000 women in reproductive age range who had confirmed COVID-19 testing. There were 8,000 women, over 8,000 women who were pregnant as part of this. And what was interesting and in some ways reassuring is that the pattern of symptoms, cough was the most frequent, but cough, shortness of breath were similar and among pregnant and non-pregnant women. But pregnant women seem to be a little less likely to have a headache, muscle aches, fever, chills, and diarrhea that was seen in the non-pregnant population. Now, this was done before we learned about the relatively common symptom of losing taste or sense of smell that many individuals experience with COVID-19. That seems to be present in pregnant women as well and seems to be relatively frequent. Also important in this information from the CDC is that chronic lung disease, diabetes, and heart disease were more commonly reported among pregnant women with the virus than among non-pregnant women. And what did they show? Well, about a third of the women who were pregnant were hospitalized, but they were hospitalized largely because of the pregnancy, not because they actually were ill from the virus. And so this statistic is a little bit misleading. And we think that probably the hospitalizations only for the virus is probably similar to the general population. In this report, at least, they seem to be a little bit more likely to be admitted to the intensive care unit, perhaps to need help with breathing, but certainly the chances of dying were not higher related to pregnancy, which is actually really, really good news. And there wasn't enough detailed information to tell whether the admissions to the intensive care or the needing help breathing were part of this. But these are the scary things related to COVID-19. Again, what was reassuring is that the overwhelming majority were either asymptomatic or had only mild symptoms. And that was the most encouraging information of all. In the data from the CDC, from the United Kingdom, and which is, of course, Britain and their related countries. In their report of 400 pregnant women, fever was the most common symptom, cough, shortness of breath, and just kind of feeling yucky. And these are things that are can be commonly seen in pregnancy. They can commonly seen in with the flu. Rhinorrhea, by the way, is just a runny nose. And this was done also before questions were asked about loss of taste or smell, but that's clear that that's a common symptom. And again, it seemed like half, maybe a little more than half of these women were delivered by cesarean. That's not the experience currently, certainly in the United States. Babies tend to do well. About a quarter needed to go to an intensive care unit, but some of those had nothing to do with COVID-19. And some of those had to do with preterm birth as well. So we think it looks like this is an exaggeration. This is not what our experience is currently in the United States. So to answer the question, are pregnant women at increased risk for severe disease, or are they more susceptible to becoming infected? From the susceptibility issue, near universal testing of pregnant women allows us to really identify more women who have the infection. And it makes us realize that there are a large number of women who don't have symptoms out there who are pregnant. And so this has led us to recommend universal testing, so everybody gets tested when they get admitted for delivery. And the overall chance of infection really appears to be similar to the general population. And that's actually really good news. As best we know right now, it does not seem that pregnant women are more likely to become infected and get COVID-19. As far as severity, greater than 80% of the cases are mild, which is similar to the general population. It's not clear right now if severe infections are worse in pregnancy. We're still learning from this. And it also is clear that pregnant women who do get severe infections often have other conditions. And what's also reassuring from some of this data is much of it is consistent, not just across the United States, but other countries. But this is an evolving story, and it still remains to be seen when we look back on this in months and years to come, what really the story turns out to be. So because of this conflicting data and conflicting information, the CDC put out really this statement that pregnant women may be at increased risk for severe illness. And they made the recommendation that they should take steps to stay healthy and reduce their risk. And they really hedged. We consider this a generic statement, and it's something that we have to look at, but it's not meant to worry patients that they will be more severe. It's actually more, I think, meant to say that it's unknown, and that it's to reinforce how important it is to take the steps that we know will help you stay healthy and reduce risk for getting COVID-19. And I'll review some of those actually at the very end here. So moving to the second question, what are the effects of COVID-19 during pregnancy on the developing baby? And I can tell you that much less is known about this. If we look at infections, viral infections in the fetus in general, we know some things about Zika and rubella, and there's some other infections called toxoplasmosis or cytomegalovirus, which are ones most individuals have never heard of before. But we do know that they can these particular viruses can cross the placenta and cause direct effects on the developing baby and affect both development of cause birth defects, but also cause injury to babies. Now, these things are not common at all, but we do know that some infections can do that. We also know, particularly from the flu, that moms who get sick with the flu are more likely to deliver early. Their babies are a little bit more likely to be smaller, sometimes related to the early delivery. They're a little bit more likely to have a cesarean delivery, and some of the babies may have a more difficult transition at birth. So we know that from influenza. And so we know the questions to ask about COVID-19, but we have less information about it. One of the reasons is really just thinking back on that timeline, that the pandemic has only been present for 6 months. And if you figure a pregnancy lasts 9 months, we really have not been able to experience much in the way of infections in pregnancy. And we just don't know a lot about this. And also, on top of that, testing has only been widely available for 3 to 4 months. But in some parts of the country, and even some parts of the world, testing is still not widely available and easy to get. And I'm sure many of you have experienced that. We're fortunate here in Gainesville at University of Florida in having easy access to testing. And part of it is because the immense research infrastructure here was able to develop our own testing methods that have been validated or been really helpful for our community. But not all the communities are that fortunate to have this kind of a resource. Now, as far as birth defects go, structural birth defects we know develop only in the first trimester. And so considering that the pandemic's only been present for 6 months, infants exposed in the first trimester haven't delivered yet. And so we really just don't know from the basis of looking at babies. We do know that limited data from ultrasound and looking for problems with the babies, there's not really yet been any reports that show a worry about an increase in any specific birth defect, which is actually reassuring for this. And so we don't think that it, there, at least at this point, we don't think that there is likely to be a big effect on birth defects, but we have more to learn about this. We do know that if you have a high fever in the early part of pregnancy, that can be linked with some very specific injuries to the baby. And so if you do have a fever, we do recommend that you contact your healthcare providers right away, and also take something like Tylenol to bring a fever down is actually a good idea, hydration and that. As far as fetal injury, we know that the virus can occasionally be found in the placenta. And so we worry a little bit about whether that might affect the baby's growth, but so far we haven't seen that effect, but we are still early in this process in learning about it. We really have no information yet that the virus in pregnancy can affect child development later in life. We have no evidence at this point that there are higher rates of miscarriage, and we have no evidence yet that the virus itself can cause higher rates of stillbirth. We're not sure yet whether changes in the healthcare system may contribute to stillbirth, but the virus itself does not look like, at least at this point, that it's a direct cause. But again, we still have very limited information about this. So just a comment about the placenta. If you take just a small little sliver of the placenta and you look at it under the microscope, these are the parts of the placenta that actually are responsible for passing nutrition and fluids and oxygen to the baby and removing any of the waste products from the baby. This picture on the bottom left. On the bottom right is actually when we magnify this. This is actually magnified about 30,000 times. It's really, really high magnification. You can actually see that there's a particle of virus, this little circle here, inside one of those little areas. So we know this can be found in the placenta, but we don't know how often this is. We think it's actually quite rare. But at least for right now, this does not look like it's linked with a specific clinical problem for the fetus. But again, I just have to admit that we don't know enough yet about this. And really the virus itself has been found only in very low amounts and only a few placentas from a few very severe cases. So I think so far we're cautiously assessing this. But there doesn't seem to be anything obvious at the moment that should trigger worries. So the next question we go to is, can the virus that causes COVID-19 be passed from the mother to a fetus during pregnancy or to an infant who's breastfeeding? So there's this whole very scientific and pretty rigorous definition of what it means to transmit the virus. How do we prove that the virus is transmitted to the baby? And so, and certainly this is not something for you to remember, but it's a pretty rigorous definition so that we can be very clear that the chances of this being the truth are high if we suspect a virus in a baby. So the mom has to have known positive virus within a very specific window of time. We know that the baby we have to be able to identify the virus in the baby's environment or in the baby within 24 hours of life, and that it also must persist with the baby after delivery as well, and the baby has to show an immune or the baby has to show an immune response. The reason why this is important is that we know that the baby can catch the virus after delivery. And so whether it's actually transmitted while the baby's still inside versus right after it's born is actually important to understand. So what do we know about the infections in the pregnancy? The most recent information that we have that actually was just reported within the past 2 weeks is on about almost 1,300 confirmed infections in pregnancy. Nearly all of those studies that were reviewed showed no evidence of transmission. Among those 1,300 confirmed infections, there were 19 cases of possible transmission to the baby, but really only 4 of them seemed to be likely. So the chance then means that maybe there's about if these are actually true, then maybe a 1 in 300 to 1 in 350 chance that a mom who has the infection would transmit the baby, the virus to the baby, which is actually, again, another really reassuring piece of information that it's extraordinarily uncommon from what we know right now that the virus is passed. But we still have a lot to learn about this, and that certainly can change as more information comes. We do know that preterm birth is more likely when you have severe disease. We do know that the infants that were suspected to have infections seem to recover quickly. We don't have any long-term data. We also know that from the information reported, so far there's been no transmission cases reported in Florida. So what about breastfeeding? And this is a story that has evolved pretty dramatically over the past 3 to 4 months. And I have to say, what we were telling moms 4 months ago, we no longer tell moms. What we were telling moms 3 months ago has also changed. What we were telling moms 2 months ago has also changed. And even 1 month ago, we changed what we were telling moms. So we know from limited studies in breast milk sample that it is very unlikely that the virus is transmitted. This one particular study found some genetic fragments of the virus, but no active virus transmitted. And then there's a number of other studies that have so far found no evidence for active virus secretion in breast milk. And there's actually been, and so this is very, very reassuring. And so although there is no clear data yet, but so far there's nothing that tells us that it's likely. One of the concerns about breastfeeding, though, is not related to transmitting the virus through breast milk. It's actually women who have the virus shed the virus from the nose and mouth, and it might be during breastfeeding, they actually cough or have secretions onto the baby, and the baby could pick up the virus that way. Because of that concern, which is actually difficult to prove, the CDC came up with the recommendations that, number one, breastfeeding is the preferable way to feed a baby, even with active infection. This is a new recommendation from the CDC. And most institutions that I'm aware of have actually adopted this policy to encourage breastfeeding. Early in the pandemic, when we didn't know much, we actually were recommending separation of the mom and baby. We don't recommend that anymore, certainly here at Shands in the University of Florida. What is recommended is that with each episode of breastfeeding, that really you pay a tremendous amount of attention to very detailed hand washing. And that's at least 20 seconds of a very thorough washing, hands, wrists, and lower parts of the arms for at least 20 seconds with soap and warm water. Or if you don't have access to that, then using an alcohol sanitizer with at least 60% alcohol. Moms should also wear a mask. and that's to actually protect moms from, protect the baby from any of the virus that might be present in the nose or mouth that could potentially drift onto the baby. If pumps are used to express breast milk, then clean and sanitize the pump rigorously. There's no science yet that shows that cleaning the breast prior to feeds will help, or cleaning the outside of the bottles and surfaces before every feed will make any kind of difference. It's not unreasonable, but we just don't have any science to make that recommendation right now. But certainly, it's reasonable to do. But we in no way, shape, or form want to make anybody feel guilty for not doing these things, because the science doesn't really. We just don't know at this point. So, to answer the question about transmission or during pregnancy or virus, transmission to the virus during pregnancy appears to be rare, but the exact risk is unknown. It's also unknown if earlier pregnancy infections can have the virus cross to the placenta. We just don't have that information yet. And breast milk does not appear to be a significant path to causing an infant to develop the infection. So the last question is, what are the other consequences of the COVID-19 pandemic on pregnant women and their babies? And there's been just a trickle of information that's coming out now that there seems to be, even though women with severe infections seem to have a little higher chance of delivering early, delivering preterm, when you look at the general population, a large group of women, actually preterm birth rates seem to be going down. And what's really interesting about that is there's some thought that not working and resting at home may contribute to a pregnancy actually being able to go longer and less likely to deliver preterm. We're not sure if that's true or not, but it's gotten a lot of attention, and certainly there's going to be a lot of research that comes to look at that. There's also at least one report that questions whether or not there's a little bit of an increased chance of stillbirth, not related to the virus, but early on in the whole pandemic, women were afraid to come to the hospital, and they were afraid to come to the doctor's office because of worries about catching the virus from the hospital and offices. And we think that that may have contributed to perhaps it not being evaluated in a timely way. Now, this is very, very, this is just one suggestion, and certainly it's going to be researched. We also don't understand fully what the impact of all of the appointment cancellations has been that occurred in the worst phases of the virus. Now, we're in a much better place now than we were even 3 months ago, because now we have much more widespread testing. We have much better availability of masks and all of our personal protective equipment things. And so we have, we're much less likely to experience the cancellations and visits and things like that. However, there's still worry in the community that certainly I see that makes folks perhaps concerned about coming to get health care. And when you look at anxiety, it's real. This was the first study that was published in Canada just last month, and they had almost 2,000 pregnant women, and over a third of them had significant symptoms of depression, and over half had significant symptoms of anxiety. And this was multiple different areas, and I'm sure we all feel this in some way, shape, or form, but it's particularly important for pregnant women. And so these are concerns about mom's own health, the baby's health, whether they have access to prenatal care, whether prenatal care is safe, whether the delivery is safe, strains on relationships, the social isolation that's also come with the disruption in all of our social connections not just with friends, but also with family. The other question has come up is, how does this impact infertility treatment? We don't have a lot of information yet on this, but the first study that came out looked at, just reported on 88 women, and there was a lot of anxiety related to delays in treatment, particularly for older women, and that's especially understandable. And there's this theoretic concern that maybe if you have a high fever early on in pregnancy, it could affect the development. So really what a lot of infertility centers have gone to is testing before and after procedures. So in vitro fertilization, egg retrievals, things like that, so that they can avoid doing any of those procedures and starting a pregnancy in the middle of infection. I think that's actually very, very reasonable. And it also highlights the importance of, around the time of getting pregnant, social distancing is incredibly important, and also the use of masks, hand hygiene, and other types of things is also extremely important. So to answer the question, what are the consequences of the COVID-19 pandemic on pregnant women and their babies? The other consequences, we're still learning about this. Ideas about true risks and best practice are evolving and will continue for years. But the medical community is committed to figuring this out. And there's just an immense number of really smart people across not just the Florida, the United States, but also around the world who are looking at this with great intensity. I do want to make a little bit of a comment on the impact of COVID-19 on the healthcare system, because I think it's important to understand a little bit what the challenges are for all of us who are trying to provide the care during pregnancy. We're still experiencing some challenges related to availability of our masks and our face shields. And this is incredibly important for protecting those who work in the healthcare field and are trying to care for all of our pregnant community, but also the non-pregnant community. And so this is just extremely important. And it's masks not just for us, but also masks for the patients we take care of to reduce the chances that we as healthcare workers can actually catch the infection, which would make it harder for us to provide care. Testing has been an ongoing challenge. And when we first got tests available, it was great, but we didn't have enough of the solution to be able to carry the virus from the sample to the laboratory. Then we didn't have enough swabs to actually take the sample. And then we didn't have enough tubes to actually hold the fluid that we could use to transmit the specimen to the laboratory. So the testing process has been a problem. There are some tests that are better than others. Some of the really rapid tests are good. Some of them are not so good. So this has been a challenge. I can tell you here, as I mentioned before, at Shands, University of Florida, we're very fortunate in our accessibility for testing. Hospital beds, some hospitals you may have heard have had capacity issues and overflow. And that affects how we take care of folks who don't have COVID-19. The challenge of keeping all of our protocols and how we take care of folks and communicating those and educating not just our staff, but our patients has been an ongoing effort because there was a period of time very early in this that protocols were changing at least every other day. And so just keeping up with this and making sure that we were staying on top of things and the most current data was being used for making decisions has been really important. Our facilities, just having all of our supplies in order, cleaning, our housekeeping staff. If you think if our housekeeping staff gets sick, that makes it harder for us to actually keep our facilities clean. We've been very fortunate in being able to protect our staff, not just housekeeping, of course, but our nurses and our clinicians. And in fact, our experience here at Shands, we've had really very few of our own employees who have developed infection. And that's because we think that our processes in place are actually so good. Most of the folks who have developed infection, though, have gotten that infection outside of the hospital. And so we've been able to identify those quickly and contain them. So we haven't had spread throughout the hospital. There's one notable exception to that, but I won't go into it, about the spread, but that actually ultimately was linked to a lack of social distancing outside the hospital. Our office protocols have changed and evolved. Many of you have been affected by our visitor policies. And this is not meant to be mean or cruel where we limit visitors, but we're actually trying to protect those of us who are trying to provide care, and also to minimize exposures to our patients and our visitors. And we're also dealing with our just so you know, our own anxieties through this process. Our doctors, our nurses, our technicians, our housekeeping, our security staff, our parking valets, we're human too, and we all have our own anxieties and our families and our own things that also worry us as well. And so we've also navigated that. And then I'm not going to dwell on it, but we all have been impacted in finances with this, which further compounds this. We've been fortunate with some of the governmental, both state and federal support that we've received, but clearly those aren't fixes. I know reports from around the country that some hospital systems were losing up to $2 million a day during the spring, during the pandemic. So really, really important. And then I just want to end on one thing. We did a survey ourselves. One of our faculty members, Dr. Rima Abu-Rustam, surveyed about 6,000 women who had appointments here, either by telehealth or by in-person visits. Over 1,000 women responded, and about 360 had pregnancy-related visits. And we know that about a third of them had visits rescheduled during the thick of things this spring. But the good news was the majority were practicing social distancing. The majority wore a mask. 40% were actually working from home. And what was really notable is what worried our patients. And they were worried, a third were worried about our clinic and office visits. Half were worried about having a delivery in the hospital. Over half were really worried and not happy about being limited to one visitor for delivery. About 1 in 5 of them were worried about themselves having possible symptoms of the virus. 2/3 were worried about the baby, and I hope I've been able to relieve some of those worries. And over 90% were really not happy and worried about not being able to have a visitor for ultrasound. And this is totally understandable. And particularly since ultrasound is such an important part of the prenatal care. And this is a very difficult, has been a very difficult decision for us, but also for every program across the country that does ultrasound. Our sonographers are present in the room for 30 to 45 minutes. And if they become sick, and develop COVID-19, then it actually brings our ability to do ultrasounds to a screeching halt. And so a lot of the restriction for visitors is not because we're mean or think somebody has the virus. We're actually trying to protect our ability to deliver high quality care safely for everyone involved. So I offer my apologies for anyone who was directly stressed at this. I know here at Shands and University of Florida, we allow the option for FaceTiming or other video visits to include other partners, but until we get our handle on this, I think most places around the country are going to do this in some way, shape, or form. We know that by and large, our moms who had telemedicine visits were happy with it, but a third of them were worried about not hearing the heartbeat, and about a quarter of them weren't sure that it was a really good option for them in the pregnancy. We hear you, we're adjusting. Only about 9% of our visits currently here, less than 1 in 10 are currently telehealth visits, and most of our stuff currently is in person, but it is a good option that we didn't have at the beginning of the pandemic. And so in summary, much is unknown, we're still learning. It's going to be a problem for a long time. It's not clear yet whether infections are more frequent or severe in pregnancy, but it doesn't seem to be, it's not obvious that it is. And we do know that other conditions may be the key to understanding that. The effects on the fetus are largely unknown. Transmission to the baby in pregnancy or breastfeeding seem uncommon. We're still learning about other effects. It's very understandable to be worried about this. Deliveries in hospitals are designed to be safe for moms, babies, visitors, clinicians, and staff, and policies will continue to change and evolve on a regular basis as we learn more about the virus. And the last thing I'm going to leave you with is that our good practices for COVID-19 are the same as they are as we're coming into flu season. So no handshakes, good hand hygiene as we talked about, masks and social distancing, and avoid gatherings. And many of you may remember from the beginning of the pandemic that the hardest thing to get was toilet paper. And this actually was an image that captured that. This actually was sent out by Tito's Vodka, as that it was a reminder that they only have 40% alcohol and that it should not be used as a hand sanitizer. So that was actually an important thing to send out, because it would never have occurred to me that somebody might consider using that for a hand sanitizer. So I just acknowledge Dr. Rasmussen and the rest of the team here, not just in our department, but across the university and Shands Hospital, that have been so instrumental in our work in COVID-19. And I'd like to stop there and open it up for questions.
Okay, thank you so much. That was some great information there. We do have several questions that have come in. I'm going to go ahead and take those now. One of the questions is, should a woman, any other special precautions that women in the workplace should be taking? And then kind of a follow-up to that is, should a woman be working in a workplace where there's contact with COVID patients?
So it's actually an excellent question, and it's one of the more common questions I get on a daily basis. And let me just take the last part of that question first. We know that when we are working with individuals who have COVID-19, that that use of the masks and the PPE and the hoods and the facial protection, that actually the chances of a healthcare worker actually getting the infection are extremely low. So the routine type of care that goes into taking care of COVID positive patients does not seem to be a reason to remove someone who's pregnant from that activity, from that work activity. If, however, the patient or the person who has COVID-19 is having procedures that are likely to create a lot of droplets, meaning things like on a ventilator or being part of a getting a breathing tube placed or having going to sleep for surgery, those exposures should be minimized. And but there's no science to say that that's justified. As far as the general workplace goes, we do recommend that the social distancing, and we recommend wearing a mask in the workplace, even if you're 6 feet apart, because you can't maintain that 6 feet apart, and also regular use of hand sanitizer. So I can tell you here in our environment here, and certainly what we're encouraging at the university, is to wear masks wherever. And we think it's good practice. We think in the middle of this pandemic, none of us are smarter to know how much is enough to do. And so what seems most reasonable is to be comfortable in the space of doing everything we know how to do to minimize our own risks.
Oops, sorry about that.
That's okay. I hope that answered.
We have another question. I've heard horror stories that if at the time of birth, the mother is COVID-19 positive, the doctors are going to separate the baby and the mother after delivery. Is that legal? What should I be aware of regarding that? I know you touched upon a little bit of that, but I'm kind of wondering if you just touch on that.
So at the very beginning of the pandemic, most healthcare institutions across the country recommended separation of the mom and baby. There was never, that I'm aware of, forced separation. But moms after delivery are very vulnerable. And so probably there was separations that occurred, that happened, that really were not done willingly on the part of the mom. We did not have our first positive case of COVID-19 in pregnancy really until May here at University of Florida in Shands. So we actually were past that period of time. We were at the tail end of the recommendations from the CDC of separating, but really what came out of that, and really what we have abided by here, is that that there's shared decision making. The CDC has very recently changed their recommendation that we here have adopted, that is that we're not recommending separation of the mom and baby anymore. We're happy to co-locate them, is what it's called. So mom with the baby. If she actually has COVID-19, then breastfeeding certainly we recommend. And with the precautions that we talked about. In between breastfeeding, we have the recommendation from the CDC still stands for having the baby placed in a bassinet in the room, left in the room, but at least perhaps not next to the bed and not keeping the baby in the bed the whole time. So trying to minimize some of that immediate exposures of the baby. Again, there's not a lot of science that backs that up, but we are not forcibly separating anybody. And certainly that is, I don't think that really would be allowable, but I'm unaware of any of it being tested in the legal environment. I know certainly it would never get to that point here.
Okay, we have another question. Is it okay to use the gym when I'm pregnant?
Ooh, so that's a very specific question. I do not have a science-based answer. I can tell you there have been clusters of infections that have come out of gyms. And so we ask everybody, particularly right now, in Florida, where, and if you remember the curves I showed at the beginning of the talk, we're still experiencing a very high rates of this infection in the state of Florida. to me, this is not the time to loosen up our activities. With that being said, we're all desperate to do things like this. I know of some gyms that have, without equipment, that have classes, bar classes or aerobic things that actually have moved them outside with the ability to do distancing when limiting participation. If anything, maybe something like that, but I can't recommend to somebody to go do it. I can tell you personally, I would feel uncomfortable doing it. And I know gyms are trying very hard to make a go of it, and they're trying very hard to do distancing, but none of these things are perfect. And so I'm just really reluctant in our current environment. Now, if we had very little transmission and very little of it in the community, I might be saying a different, something a little bit different. But right now, I think we're still in the thick of a very messy circumstance. Also, with going back to school, we don't know what the impact of transmission in the community is going to be. So I would actually err on the side of caution and not put myself in those kinds of environments.
Okay, sort of a related question to that. Is it safe for my older child to be at daycare if I'm pregnant?
So this is a little bit out of my area of expertise with daycare. And some daycares we know have operated successfully in preventing transmission and have had very pristine records. I can't tell you specifics about Florida and what the experience here is. So it is possible to do that. I know that daycare is necessary in many circumstances. And so there's no way around it. Just like school, there's no way around some of it. It is a very difficult decision for families. I can tell you our own doctors and nurses are just as worried and concerned about this as our pregnant women are. And I don't know that I can answer that with a easy yes or no. We're all struggling with this. If there are alternatives, that seems to be what a large number of folks are choosing, but not everybody has alternatives, in which case we navigate this. And the data I showed you earlier and some of what I talked about, hopefully, is somewhat reassuring that that the risks are don't seem to be dramatically worse, but we're not very good. We're not smart enough yet to understand who is going to be an individual who gets a severe infection and who has mild. So we're not able to pick that out. And so we're really very, very cautious. There are many people who believe that it's a little bit early to open the schools, to open the a lot of the daycare settings, to in-person kind of things. You can't really do daycare outside remotely, but it's not been my area of expertise. Perhaps a discussion with the pediatrician would be a better way to go to understand that. But it's a lot to consider. It's very, very challenging. Yeah. But nobody should fault and place blame on somebody if they make that decision to choose either healthcare, daycare, or going back to school.
Okay, thank you. Another question is, I'm 6 months pregnant. What kind of precautions should I take when I'm traveling?
Depends on the travel. That's a big one. I don't know. So were the recommendations regarding air travel? Air travel itself is considered safe in pregnancy, but with COVID, it is not. You're unable to do the social distancing. Masks may help a little bit, so our recommendation generally is keep it to essential travel only, whatever your definition of essential is. We're not recommending leisure travel. Car travel still seems to be fine. Renting a place or Airbnb, not that I'm endorsing Airbnb, but an equivalent type environment for a brief period of time, and cooking your meals in a place and not going out to restaurants or clustering in large groups, I think should be considered. Is being outside better than being inside? As far as risk for transmission around people, absolutely it is. How much of a protection? It's not an absolute protection. I can tell you, I have gone myself personally kayaking in some of the springs and have been in environments that I was more nervous because of all the people there than I am actually coming to work. So I think it really depends on the circumstance, and the same principles are going to apply no matter what your circumstance, whether it's home, work, grocery store, gym, travel, beach, whatever.
Okay, thank you. Another question. What are your recommendations when it comes to family members or friends visiting after the baby's birth? Obviously, wearing a mask, washing hands, and also, should I enforce a mask rule while they're holding the baby?
So what is considered probably the highest level of protection would be to limit visitors. It's not always possible, and certainly moms need help. And so a help, whether it's family member or somebody else, is great, but the social visiting, probably the highest level of minimizing exposures is to limit those. And for those who do come in to provide help and support, masking, I think, is probably appropriate, just like with breastfeeding. Is that enforce a mask rule? Certainly for other people within your household, if they're going to be frequent within your house, that may not necessarily be needed. But if people coming in just on short times and they've been out in the community, then it's not unreasonable to do that. Again, a lot of these things are trying to balance what we're doing, and there's nothing normal about this process right now for any of us within our communities, within our homes, within our workplaces.
Okay, another great question. If a baby is born to a mother with COVID-19 and or breastfeeds from a mom with COVID-19, would that help give the baby any antibodies against it, do you think?
We don't know yet. And so there's not a lot known about the antibody transmission from mom to baby. And whether that gives some protection. We know that for other infections, it absolutely does. And that's why we recommend some specific vaccines in pregnancy, particularly the whooping cough, the pertussis vaccine, and the flu vaccine. So these are actually really, really important in pregnancy. And this is probably a good time to put a plug in for please get the flu vaccine during pregnancy. That will actually decrease the chance of getting the flu and actually having to go through the process of thinking you might have COVID-19. And we are very concerned, without any science yet, but we worry very much if a mom gets both the flu and COVID, that is a recipe for very, very bad illness. So we are hopeful about those antibodies, but our antibody testing is actually still very, very new. And so we don't know a lot about that. And so more to come. We hope that happens, but it still remains to be seen.
Thank you. We have a question from a mom whose spouse is going to be on pre-deployment when they're scheduled to deliver. and the Red Cross can help allow him to come home, fly home for the delivery, but they're wondering, should they not attend, should he not attend the delivery since they won't have a period of isolation after traveling?
So the CDC, I believe you'd have to look at their website to see about the travel. I believe it depends where he's deployed and what his the area he is. Some would argue actually Florida is one of the highest rates of infection, and you know that New Jersey and New York had actually asked to quarantine folks coming from Florida, where we tried to do that for them. So you know, there's this whole back and forth. By and large, what's happened is when somebody comes home, if it's a just-in-time arrival, we would do the screening. And if there's no symptoms, we would probably allow that person with a mask. Certainly, if there's an ability to get tested, that's the best once you arrive home. But we know those things, there's often not a lot of lead time. But certainly in our environment, we would try and be reasonable about that to try to allow participation here in that process. Great question. These are all, by the way, wonderful questions.
Yeah, they're good questions. Yeah, I agree. Here's another question. What's the average hospital stay? Once a baby and mom go home, what's the protocol for visitors who are coming to travel to kind of help out? So I think we answered that a little bit, but what's an average hospital stay?
So our experience in most places has been that there does not seem to be a prolonged hospital stay. So moms are seeming to go home on time, whether they have a regular vaginal delivery or whether they have a cesarean delivery, which is actually very encouraging. Obviously, if a mom is sick from the illness and is struggling herself, they're going to be kept here in the hospital because of that. We're fortunate here at Shands is we have a whole separate area of our labor and delivery unit that allows us to care for moms who actually have a COVID-19 infection or is suspected to have one, that keeps them separate from our other patients. And so it's not separate, it's not a different level of care, but it allows us to actually provide some separation so that we can concentrate our nursing staff on specific types of conditions. So the short answer is that stay does not seem to be prolonged as long as there's no other illness that's prolonging it. From the baby's perspective, babies are also being discharged in the same level, but if they have a problem, whether it's from a preterm birth or for some other issue, they would stay anyway, and it's not specifically because of just worry about COVID-19. And I hope I answered the question about the home process.
Okay, and then kind of a follow-up to that. Do you think that maybe family members should try to quarantine 14 days before a birth if they possibly could, because they're going to come help out?
So I actually think that that's quite reasonable. And I say that taking off a doctor hat and just putting on kind of, is that something reasonable to do? And the answer is, I think yes. I think it's a very good idea. But again, we don't have science. It actually increases your level of confidence that you're lowering your risk. And I say that kind of in the context of much of this feels like such an out of control circumstance. There's not a lot about this that any of us, and certainly not those who are pregnant, feel like they have any control over. Certainly on our healthcare side, there's some things we can control, but in some way that's taking away some control from those moms who are pregnant, and that trying to control that that exposure thing is one thing that our pregnant moms do have control over. And so I think it's actually reasonable. Whether it makes a difference or not is a different story.
Okay, could you tell me if remdesivir is safe to give during pregnancy?
There's very limited experience with that in pregnancy. It has been used, what we can call a compassionate use request in various places across the country. It does not appear that it causes any harm. And the jury's still out about whether even outside of pregnancy it makes a difference. And some of you are aware that there's a very recent publication that called into question whether or not it actually makes a difference. With that being said, it's one of the things that is improved. And for a mom who meets the criteria for somebody to receive it who's non-pregnant, we would certainly consider it and offer it potentially in pregnancy. But that actually goes through a specific protocol. And it's not that, pregnant COVID, let's order it. It really is pretty stringent, but we're not afraid to do that. And perhaps one of the principles I should put out there is that in general, if something is good to take care of somebody who's not pregnant, it should be used to take care of somebody who is pregnant. There are some specific exceptions to that, but we don't stop taking care of individuals just because they happen to be pregnant.
Okay. Is there an increased clotting in patients that are postpartum and have COVID?
So we've actually, we don't have enough information yet to know whether that risk becomes significant in pregnancy. We do know that the recommendation right now is that if a mom is admitted for a medical reason before it's time to deliver and they have to be in the hospital for a prolonged period of time, we use just a little, it's recommended to use just a touch of blood thinner just to reduce the chances of clotting. Many places, including us, actually do that anyway, even outside of COVID-19. If somebody has a C-section and has COVID-19, we also would do the same thing. If they are sick here in the hospital, then yes, I think that follows under the protocol of giving some blood thinner to prevent coagulation. But that's actually not based on pregnancy experience. It's just based on, yeah, that seems very reasonable given what we know about clotting in pregnancy. But there's not a lot of experience that shows us women are much more likely to have serious clotting issues if they're pregnant. So.
Okay. Could you address pregnancy and going into a public pool?
I wish I could. I don't know the answer about the treatment of water, the chlorinated and the other chemicals that are used on COVID-19 virus. And it's pretty hard in some of those circumstances to social distance. And so I think I fall back on the issue of weighing benefit versus risk. So a pool that you have your own lane for swimming laps, and they only allow every other lane, and there's only a couple of people at the pool at the same time. That might be different. I say that without having any science or data to back it up. It might be different than a community pool that have the kids running around splashing, and or perhaps one of the freshwater springs in Florida that has a ton of people that are wall to wall across the banks, as an example of an outdoor place with the water. But I don't think anybody has that answer.
Okay, yeah, I understand that. Last question I have here. How could a mother protect a 1-month-old baby in a community where not everybody is compliant with masking?
Ooh, again, this is a little bit out of my area of expertise. I think the same principles apply that what we've talked about. What I would like to say, at least here in the Gainesville immediate community, I've been highly impressed at the community participation and the masking and hand hygiene, but that's not true in all communities. And so I think that the same principles are going to apply across the board, and none of us, no matter how hard we want, are able to control the actions of others. And that creates some additional anxiety, as if there's not enough in our lives these days. And really, I've actually seen in some individuals actual anger expressed because somebody doesn't do what others want them to do, whether it should be the right thing or not. And that's just a really, really difficult thing to navigate. And it's very hard to do. Ultimately, we can only control ourselves in our own environments. And that's what I would use to, as your best tool for navigating what you're seeing around you. Many of us have grown to accept some degree of the rest of the world that we cannot control, but we can control much about our own world.
All right. I really want to thank you for taking the time out of your busy schedule to talk about this very important topic. And I want to thank the audience for attending and providing some great questions. I also want to let you know that there's a survey when you finish the webinar today. A survey should pop up after you close things, and I'd love for you to give us feedback there. I'll be happy to share that with Dr. Smulian and his team. So that's a great way to get feedback in their hands and let them know what they thought or any other follow-up questions, and see if I can help you with that. So thank you for taking time out of your day today, Dr. Smulian, and you guys have a nice day.
Thanks, everyone.